I'm Mark Shackleton, the Director of Oncology at Alfred Health and also the head of the MPCCC's Precision Oncology program. And welcome to today's seminar, which is going to continue a now fairly long line of really excellent presentations under this important theme. I'd like first to acknowledge the traditional owners of the land on which we join together from today and respectfully acknowledge their elders, past, present and emerging, as well as any members of the Aboriginal and Torres Strait Islander communities that are gathered amongst us this afternoon. The MPCCC Precision Oncology program is a community of scientific researchers and healthcare workers and academics across Victoria that have an interest in precision medicine. We're currently working to establish better access to molecular sequencing for cancer patients, particularly across southeastern Victoria and into regional areas. And we also host numerous tumour-specific molecular tumour boards that support clinicians in the interpretation and application of molecular sequencing data. These seminars that we're hosting today are a very important part of our overall program as they help to share the latest research in this field from across the partnership, as well as across Victoria, nationally, and even internationally. So without further ado, for today's seminar, this is our final seminar for 2021. I'm very pleased to welcome Dr. James Lee. James is an academic endocrine surgeon at the Alfred Hospital and Monash Health in Melbourne, and he also has rooms at the Epworth as well as Knox Private. His main clinical interest is in the management of patients with thyroid, parathyroid and adrenal cancers, so endocrine tumours, and his research is in the personalised care of patients that need thyroid surgery, particularly the discovery of molecular biomarkers to improve the diagnosis and prognosis of thyroid cancer. Very interesting and important area. His current research is supported by the Epworth Research Institute, the Aftershock Program and Impact Philanthropy. James is a member of the ANZ Endocrine Surgeons Executive Committee, the ANZ Thyroid Cancer Registry Steering Committee and the Cabrini Research Committee. And his topic today is the evolving role of molecular markers in the management of patients with thyroid cancer. There'll be a few minutes for questions at the end of the presentation, but until then, I ask you to mute your microphones and turn off your video so we can keep distractions to a minimum. Thanks a lot, James. Over to you.
Thank you, Mark, for that very kind introduction, and I'm really humbled to be invited to give this presentation. So thank you for the presentation. I also like to thank you for being such a good colleague and mentor for me for the last few years. So as Mark said, good morning, everyone, or good afternoon, everyone. As Mark said, I am an endocrine surgeon. So a lot of what I'm going to talk about today will have a heavily surgical flavor to it, and how as surgeons, we can also make use of the precision medicine to help us better provide care for our patients, not just surgically, but also as part of the multidisciplinary team. So I'm going to go over just very briefly the overview of thyroid cancer management, and also what are the main diagnostic challenges and its implications and what we can do about that, as well as towards the end, some targeted therapies that are available for thyroid cancer patients with advanced disease. And then I will give sort of towards the end my thoughts on how we should move forward with this in this area for these patients. So there's no secret that the incidence of thyroid cancer has been increasing over the last 3 to 4 decades. It's practically quadrupled over the last 3 decades. And these are Australian data. On the left-hand side, you can see, especially for females, this light blue line has continued to increase and shows no sign of slowing down. But fortunately, the mortality in this green line down the bottom remains low for the majority of patients. And on the right-hand side, we can see that, especially for females, the peak incidence of diagnosis is in the 5th and 6th decades, and mortality increases with with time, with age. So that's the Australian data. So a few years ago, I came across this article from the Alfred Surgery Archives of thyroidectomies that were done 50 years ago. So we sought to compare what the indications of surgery and how many cancer patients they operated on back 50 years ago. So in the historical cohort, there were 746 patients altogether over a 14-year period, and they had 8% of the patients diagnosed with thyroid cancer, compared to our contemporary cohort of 790 patients over a 10-year period. That percentage has gone from 8 to 27. So the increase in thyroid cancer diagnosis is something that is seen both internationally, nationally, and now locally as well. And of course, thyroid cancer is not a homogeneous group of disease. It is, in fact, a group of disease with a spectrum of disease with quite different behaviors. And on the one end, we have the anaplastic thyroid cancers, the poorly differentiated thyroid cancers with very high mortality rates. And targeted therapies for these diseases is currently a hot topic. Whereas on the other end of the spectrum, we are also increasing our knowledge in the low risk or the very low risk end of the spectrum. I'll give you some examples before I come back to talk about the more advanced diseases. So there's this entity called that used to be called the follicular variant of papillary thyroid cancer that's encapsulated without any invasion. In fact, that entity, which makes up 17% of the papillary thyroid cancers, which is the most common type of cancers, have now been downgraded to be called NIFT-P, or non-invasive follicular thyroid neoplasm with papillary-like nuclear features. Quite a mouthful. It's basically a very fancy way of saying carcinoma in situ, so not really a cancer anymore, so it's been downgraded. Also, a lot of the increase in the incidence of thyroid cancer diagnosis is in what is now called microcarcinomas, measuring less than 1 centimeter in size. And led by the Japanese surgeons, these patients with microcarcinomas are now being managed with active surveillance. So they have published their guidelines, and it's not, the uptake of active surveillance is not as widespread in Australia, but it's starting to evolve over time. But in their guidelines, they show that in a 5 to 10 year follow-up period, only less than 10% of them show any signs of growing more than 3 millimeters or more. Even though to a clinician, to a thyroid clinician, 3 centimeter growth in a microcarcinoma doesn't sound like a lot, but try telling a patient that your cancer is growing, but we're still not going to take it out. That is more challenging. Also, they showed that in these patients with follow-up, the development of lymph node metastasis only occur in a small percentage. And if that does occur, salvage surgery does not affect their, does not reduce their survival overall. So they feel that as a group, the microcarcinomas are very safe to be under active surveillance rather than active treatment initially. Also, in the common garden variety of classic variant papillary thyroid cancer, there is a push towards de-escalation of treatments over the last 5 to 10 years. And we've seen that happening right here at the Alpha and Monash. So a few years ago, we published the trend of the use of radioactive iodine after the 2009 American Thyroid Association guidelines. After it's been published, revised and published in 2009, we found that the rate of the use of post-operative adjuvant radioactive iodine dropped from 66% to 48%. And of those that received the radioactive iodine, they also received a lower dosage on average. And this is between groups of patients with similar demographics and similar thyroid cancer stages. Similarly, because we're using less radioactive iodine ablation, we're also able to treat these patients not with total thyroidectomy, but increasingly with hemithyroidectomy, as demonstrated on this graph on the top. Here, before the again revised 2015 guidelines, only 5% of thyroid cancer patients were treated with less than total or hemithyroidectomy. But after the guidelines, we're now treating about 20% of our cancer patients with hemithyroidectomy, which has its advantages of being a lesser aggressive surgery. Again, the two groups have similar demographics and disease stage. Similarly, we used to perform prophylactic central lymph node dissection in 80% of papillary thyroid cancer patients, and we now perform about 20% of those. So as you can see from those last few slides, that thyroid cancer used to be treated as a one-size-fits-all approach, with thyroid cancer equating to total thyroidectomy and adjuvant radioactive iodine ablation. And we're now in a more nuanced and stratified approach era, where the extent of surgery and subsequent management depends on the characteristics of the tumor and the characteristics of the patient, and those with less aggressive disease are being treated with less aggressive methods, and those with the aggressive disease are still being treated aggressively. But we're now entering into the age of precision medicine, where we seek to learn about the biology, the molecular biology of these tumors on an individual basis, and also predict the effectiveness of the therapies that we use, and then treat these patients accordingly. So what are the potential areas that precision medicine can be applied in the treatment of thyroid cancer patients? I think they can help confirmation or exclusion of thyroid cancer prior to surgery, and I would go into a little bit more detail of this in the next few slides. They can also be used to predict the behavior. And again, as a surgeon, if I know that this disease is likely to behave aggressively, then I will then be able to operate more extensively, taking the risk of complications that comes with more extensive surgery. But if the disease is not going to behave in an aggressive manner, then we will pull back in the aggressiveness of our surgery, and therefore avoiding these complications. They can also be used to predict sensitivity to radioactive iodine, and also the likely way the disease aggression is going to behave. And finally, for the more aggressive disease, they can also be used to predict their response to targeted therapy. And in the other end of the spectrum, we may even be able to discharge patients from long-term follow-up. So let's just take a step back and see how thyroid cancer is normally diagnosed. These patients usually present with a lump in the neck, or their thyroid mass is found incidentally on one of these imaging modalities. And they all get assessed by a clinician with interest in thyroid cancer care, and almost all of them would go ahead and have an ultrasound. The ultrasound is able to provide sort of a grading of suspicious in features. So those with less suspicious features do not require further workup with a biopsy, but those with highly suspicious features, depending on the size of the tumor, may be recommended a biopsy to follow, and there's a grading across that. So those that end up having a cytology, 70% of these cytology are benign, and they are called Bethesda category 2. There's a risk of malignancy of less than 2%. On the other end of the spectrum, less than 10% of these cytology turn out to be malignant, and there's a 99% risk of malignancy if you took the tumor out, and those patients need surgery. But there is this category in between of 20 to 25% of patients who've gone through the trouble of having an ultrasound, having a biopsy, but the result is indeterminate, meaning we cannot tell with any degree of confidence whether this tumor is benign or malignant. And that's what we call indeterminate, and it includes Bethesda category 3, 4, and 5. with a risk of malignancy in Bethesda 3 of 15%, and that goes up to 80% with Bethesda 5. So, in a range where we can't use that information to really make sound decision right from the beginning. And these patients usually end up having a diagnostic hemithyroidectomy or having surgery for the diagnosis. So we were interested to see, in terms of surgery, what difference does it make whether the patient has a definitive cytology, whether it's benign or malignant, or if they had an indeterminate cytology. So we found that patients who have a definitive cytology from at the outset before surgery, 96% of them went on to have the appropriate initial surgery the first time around. The 4% may require further surgery for completion thyroidectomy for one reason or another, usually because of intraoperative issues with the recurrent laryngeal nerve. On the other hand, patients who have a indeterminate cytology, only 41% of them received appropriate surgery initially. So 42% of them did not have any other indication for surgery other than the risk of malignancy of the nodule, meaning that they don't have a large goiter that is compressing on their trachea, they don't have Graves' disease, they don't have any other reason to have surgery other than the fact that the nodule, which is otherwise asymptomatic, has a risk of being malignant. So those patients potentially have been overtreated if we had known about their benign lesion before the surgery. They could have avoided surgery. And the rest of them, some of them required completion surgery because it turned out to be cancer, and some of them did not receive a central lymph node dissection, which if we had known about the cancer diagnosis, we might have recommended that to start with. So these 17% might have been undertreated the first time around. So the reason why we accept a certain percentage of indeterminate cytology is that one type of thyroid cancer, being the follicular thyroid cancer, cannot be diagnosed based on cellular features alone. So papillary thyroid cancer can generally be diagnosed based on nuclear features, and medullary thyroid cancer can also usually be diagnosed by cytology, but follicular cancer needs to be diagnosed based on the evidence or demonstration of capsular invasion and vascular invasion, both of which require histopathology slides of the whole tumor to be able to determine. So we would expect that within the indeterminate cytology group, most of them will end up being follicular thyroid cancer. But that is really not the case when we reviewed our results for this study. In fact, 2/3 of the indeterminate cytologies ended up being papillary thyroid cancer, which I guess in a way may be good news because there are ways we can try and increase the diagnostic capability of this subgroup, and I'll talk you through that. In 2014, the Cancer Genome Atlas Network published a landmark study detailing the landscape of papillary thyroid cancer mutations of using 500 tumor samples. They looked at somatic mutations, fusions, as well as copy number variations. They found that using somatic mutations alone, they can determine the driver mutation in 74% or 73.6% of the tumors. By adding RNA fusions, they can determine the driver mutation in 89%. And by adding copy number variations, they can determine the driver mutation in 97% of the patients. So which means that only 3.5% of these 500 tumors that they were not able to determine what's the driver mutation for that. What they also did was they categorized these tumors into V600E BRAF-like tumors or versus RAS-like tumors. BRAF and RAS mutations in papillary thyroid cancer are two driver mutations that are mutually exclusive, but not all of the driver mutations were either BRAF or RAS. So they used a 71 gene signature to determine for those tumors that are neither BRAF or RAS mutations, what were they? And also even BRAF mutations that were not V600E mutations. So they were able to categorize them into one of these two categories. And the clinical significance of that is these two BRAF-like and RAS-like tumors behave quite differently. BRAF-like tumors are more likely to metastasize to the lymph nodes, therefore more amenable to head and neck surgery. And they are also more likely to be radioactive iodine refractory. Whereas RAS-like tumors, they're more likely to metastasize to distant sites, and they are less likely to become IAI resistant. And the other thing they have found was that the RAS-like tumors, when they use the expression of 16 thyroid metabolism function genes, they could determine the degree of differentiation and they gave all the tumors a score. They found that the RAS-like tumors all tend to be more well differentiated, hence retaining the radioactive iodine avidity, whereas in the BRAF group, there is a wider range of differentiation. You can see here blue and pinks on the left side and mostly pinks and reds on the right-hand side. So there are clinical significance there. So what can we do with that information in our group of patients with the indeterminate cytology? In fact, there are molecular adjuncts that have been used over the last 10 years in the United States. There are actually at least three different commercially available systems to determine the molecular makeup of these cytology samples to help increase the diagnostic rate of these indeterminate cytology samples. But unfortunately, none of those are routinely available in Australia. ThyroSeq has an international presence, but they have hubs in Singapore, Mexico, and Australia. And just yesterday, I've learned that they're starting to provide services in Australia, but it is early days and we don't know what the medical legal implications or the funding implications are just yet. So with that said, that's inspired us to try and come up with our own system or our own panel of genes through NGS to set up a similar system here locally in Melbourne. And I know both the molecular pathology departments at Monash and the Alfred Hospital are able to provide this service on an ad hoc basis at the moment. But 3 years ago, we collaborated with a lab in Peter Mac to set up the system. So, and it was funded through, as Mark said at the beginning, in the introduction, by Epworth Research Institute, Perpetual Philanthropy, and the Aftershock. So over the last 3 years, we recruited 130 patients. 115 of those ended up in the study, with the rest of them being used for validation and initial optimization purposes. And we collected 132 FNA samples and 30 malignant tumor samples. And so far, we have almost finished sequencing the FNA samples, 113 of them. And the success rate, unfortunately, was a little bit lower than what we would have liked, probably because of the way we handle the tumor, the sample. So the FNA samples, initially, that sort of degraded its quality. So the success rate was about 77% so far. So what we did was we, in patients who are about to undergo thyroid surgery, we obviously have the information, pre-op information of their cytology category, their clinical information. And intra-op, when they come in for surgery, under general anesthetic, under ultrasound guidance, we take an additional study FNA sample, which is then kept in a preservative solution for up to a week in room temperature for transport purposes, but as soon as it reaches the lab, it gets frozen. So it took us a little while to work out this workflow as well. And post-operatively, we then have the final histopathology as well as the BRAF immunohistochemistry results to compare to what we see on the NGS panel that we perform on these FNA samples. And we performed that using the Archer system, both DNA copy number variation and RNA fusion. So here are the results so far. Of the 75 patients, we had 87 FNA samples. the mean age and sex distribution typical of thyroid cancer patients. We have focused on collecting samples from patients who had indeterminate cytology, but we also collected some benign and malignant samples just for comparison and baseline. And as you can see, the tumor size is 3.5 centimeters. So we didn't really collect the really small cancers. So out of these 87 samples, we found 33 somatic mutations. 2/3 of those were BRAF V600E mutation. We didn't see any other BRAF mutations. A handful of RAS mutations, and then this GNAS TP53 and P10 mutations as well. We also found 4 fusions, 3 of which were RET fusions, and 1 was PPAR gamma. So these are what were thought to be pathogenic mutations. There were other mutations that I haven't listed here that were thought to be either an artifact or non-relevant. So this table here then maps out the mutations versus the final histopathology. The tumors above the red line are malignant, and those below the red line are benign. And as we can see here, as previously published in the literature, BRAF V600E is strongly associated with malignancy, as are RET fusions and PPAR gamma fusions. TP53 may be associated with malignancy, but usually with the PTC, so I'm not quite sure yet the significance of this particular mutation here. The others are difficult to tell because they are across both malignant and benign histopathology. RAS mutation is known to be associated with both follicular cancers and benign follicular lesions, but whether those lesions with those benign lesions with a RAS mutation are more likely to go on to become malignant in the future is still a subject of current investigations. And if that turns out to be true, then removing these lesions are clinically relevant as well. We then compare the immunohistochemistry BRAF status and the NGS BRAF status from the FNA samples. Of the PTCs we had 24 with known BRAF immunohistochemistry status, and 80% of them were mutation positive. So that's a high percentage. Probably one of the highest in the literature. And out of the 38 malignancies, 32 of them were PTC. So there were no false positives in the NGS mutant group, and there were 3 false negatives. And again, we will need to look into more whether those are due to technical reasons, because I know one of them had 2 FNA samples from the same tumor, so it might be due to tumor heterogeneity, and the other patient had 1 sample from the primary tumor and 1 sample from the nodal metastasis, and perhaps that also one of those was the benign, so the false negative one. So what does this mean for our indeterminate patients with indeterminate cytology? So out of the 61 patients with indeterminate cytology in this group that we've analyzed so far, we found 12 BRAF mutations on NGS, 3 fusions, and 1 other PPAR gamma fusion. So in total, 16 out of the 61, which is 26% of them, could have had their malignant diagnosis made prior to surgery, and therefore helping us improve the exact extent of the initial surgery. I'm not saying that every patient with an indeterminate cytology should go on to have a molecular test, and therefore, but what I'm suggesting is that with this technology and with this knowledge, we need to come up with a pragmatic, patient-centered approach to incorporating this into our workflow, taking into account the pros and cons, the strengths and weaknesses of the testing, and asking ourselves whether the molecular results would make any difference to what we do initially surgically. So I'm going to move on in the next 15 minutes or so to talk about the other end of the spectrum, towards the other end of the treatment spectrum, and also aggressive spectrum of advanced thyroid cancers. Again, it's always good to know our own data, how many of these or what proportion of thyroid cancer patients we treat can be considered advanced cancers. Although using MDT data might be a little bit biased, because the more advanced patients with the more advanced disease are more likely to be discussed in MDT, but nonetheless, of all the patients discussed over a 12-month period from mid-2019 to mid-2020, 41% of them were considered to be advanced cancers. And within the advanced cancer group, there was overrepresentation of follicular cancers, poorly differentiated cancers, and medullary cancers. So this graph breaks down those different cell types, but also cancer types, but also the behavior that allow them to be categorized as advanced cancers. So most of them were regional metastasis to lateral lymph nodes, especially in PTC, but also recurrent disease, locally advanced disease, radioactive iodine refractory disease, and distant metastasis. And it is these radioactive iodine refractory disease patients, and also those that we don't expect that they would take up radioactive iodine, are the ones that are of interest for a molecularly based TKI therapy. And I just want to also remind people that radioactive iodine itself is a targeted therapy, and which in fact was the first targeted therapy developed for any sort of cancer that has been routinely used for thyroid cancer over the last at least 50 years. But the downside of that is they can only be used by well-differentiated thyroid cancers which retain their sodium iodide symporter function. So with more advanced cancers, and often in recurrent cancers, they lose that function. So when that happens, other targeted therapy have been approved, and for differentiated thyroid cancers, the two drugs that's been approved are lenvatinib and sorafenib. For medullary cancer, cabozantinib and vandetanib, and for anaplastic cancer, dabrafenib and trametinib, which are so the top four are multi-kinase inhibitors, whereas dabrafenib is a BRAF specific inhibitor and trametinib is a MEK inhibitor. So I'm going to go through these very briefly, and I'm going to start with anaplastic thyroid cancer because they are the most aggressive type of thyroid cancer, and the patients stand to gain the most with this new type of therapy. And just a reminder that all anaplastic thyroid cancers are stage 4 cancers. There's no such thing as a stage 1, 2, or 3 anaplastic thyroid cancer, but they are subdivided into stage 4, A, B, and C. For patients with stage 4A disease, which is defined as disease that are confined to the thyroid without any obvious invasion, surgery is possible, and these are the patients with a potential for medium to long-term survival. The median survival for all anaplastic thyroid cancers is around 5 to 6 months, so very aggressive cancer. So we need to act fast. In these patients with disease confined to the thyroid, if it's possible to perform a microscopic or macroscopic resection, complete resection, then surgery should proceed. But debulking surgery is generally not recommended, because there's a whole saying that if you operate on someone with aggressive anaplastic thyroid cancer, you can see the tumor recur through the wound before it even heals. And they're often treated with adjuvant chemoradiation as well. For patients with stage 4B disease, with local invasion within the neck and local regional invasion, again, surgery is resectable, but often they may not be. Either way, whether they're resectable or not, upfront molecular testing is now the recommendation. It's now the standard of practice. At the minimum, BRAF V600E mutation should be tested, but preferably other mutations as well through NGS. And while waiting for the mutational status to come back, high-dose chemoradiation can be used as a bridging therapy, and if BRAF V600E mutation is confirmed, then the recommended therapy is a combination of dabrafenib and trametinib, the BRAF and MEK inhibitors. If other mutations were seen on the NGS testing, such as ALK, RET, and NTRK fusions, there are also targeted therapy for these. So a little bit beyond my expertise in those. And also there has been case reports where after the targeted therapy, the patients who may not be initially operable becomes operable, and resection is recommended in that situation. If the patients progress through the therapy, then palliation is probably the preferred option. As is for stage 4C disease, usually upfront palliation is the most appropriate course of action. But if for whatever reason aggressive treatment is deemed appropriate, then the similar therapies with the dabrafenib and trametinib, as well as other targets, and in addition, immunotherapy with a checkpoint inhibitor may be possible if there's a high expression of PD-L1. So just a couple of studies using these therapies. So this one, this study had 15 patients with anaplastic thyroid cancer with the BRAF V600E mutation, and they were treated with a combination of dabrafenib and trametinib. And you can see here that the majority of them had at least partial and one complete response, and the rest of them, the 3 of them, were stable in their disease, and only 1 with disease progression. And on the panel on the right here, you can see mediastinal mass, pleural mass, and lung mass all significantly reduced after 8-week therapy on this combination. They also show that the disease response was relatively durable. In this other study from MD Anderson, they categorized, or they grouped their patients with anaplastic thyroid cancer over the last 20 years into 3 different time frames. In the earlier days, 2000 and 2013, they were treated with chemoradiation mainly. And then in the middle time period, 14 to 16, they started to treat them with targeted therapy. And in 17 to 19, they added post-neoadjuvant therapy surgery to these patients. So they found that over time, there was more testing and more targeted and immunotherapy, as well as more trial enrollments and surgery in that last time period. And throughout these periods, they emphasized that the patient demographics and disease stage were all similar. So you can see from the graphs here that with the newer therapies, they're achieving better overall survival. In their subgroup analysis, for those patients that went on to have surgery post BRAF directed therapy, those that had surgery had better 1-year overall survival, and then those that did not go on to have surgery, perhaps there may be some selection bias there. It's hard to know. And overall, they also show that the median survival is doubled in patients treated with targeted therapy. So I'm going to move on to medullary thyroid cancer. Now, this flow chart is just to show you that the current recommendation for medullary thyroid cancer, the systemic therapy with tyrosine kinase inhibitors is sort of the last line of defense for these patients. And the 2 that have been proven to improve progression-free survival are vandetanib and cabozantinib. For vandetanib, the median progression-free survival is 13 months in the treatment group and 19 months in the placebo group. And for cabozantinib, the median survival for disease progression-free survival was 11 months, and in the placebo group 4 months. So, but it's interesting that in the placebo group, the difference between 19 and 4 months in these 2 studies. And those studies led to the recommendation by the American Thyroid Association to use them as single agent first-line systemic therapy in patients with significant tumor burden and those that are symptomatic or progressive with metastatic disease. The overall survival benefit for these treatments are still unclear, and also there's a significant proportion of patients who suffer from adverse effects, and the most common of which is diarrhea, which is unfortunate because one of the main symptoms with patients with metastatic thyroid, medullary thyroid cancer is diarrhea because of the high level of calcitonin and liver metastasis. So having diarrhea as your treatment side effect is really not desirable. So to manage or to counteract that, there's a newer medication called selpercatinib, which is a specific inhibitor for RET mutations, and 100% of familial MTC patients have a RET mutation, and 65% of sporadic patients with MTC also harbor this mutation. So this will be useful in a large proportion of patients. So in this phase 1 and 2 study, they recruited both patients who have previously been treated with one of the other 2 medications and those that are treatment naive. And as you can see from both of these waterfall plots, a significant proportion of them had, those that go beyond this dotted line, have response to the treatment, and the rest of them have stable disease. Only a couple of them had progressive disease. From the same study, they also reported the patient-reported outcomes of these patients, and throughout the 13 cycles of treatment. And you can see here that the yellow and the blue suggest that the patients have either improved or stable global health status, with only a small proportion of them with worsening health status. And they also looked at diarrhea as a side effect specifically. And as you can see here down the bottom with the green, a very small proportion of them ended up with this symptom. So what does this mean in terms of in comparison to the other multi-kinase inhibitors? Is being investigated by this current phase 3 study, which is currently recruiting, including in Australia. They are going to compare selpercatinib to the other TKIs. Of course, so these patients cannot have any prior history of any TKI treatment. So we're awaiting the outcome of this study. So finally, let me move on to radiorefractory differentiated thyroid cancer and the concept of re-differentiation. Again, just to show you that using the TKI is sort of the last last resort for these patients. Although the knowledge of molecular diagnosis and molecular risk stratification may be useful much earlier on in the process of the treatment. So sorafenib and lenvatinib are the 2 drugs that are approved. Again, similar sort of Kaplan-Meier curves, with sorafenib showing double the median survival time as were lenvatinib. But again, the overall survival benefit has not been proven. There is significant adverse effect as well, and the overall quality of life data is also limited for these drugs. So you can see significant grade 3 side effects or more severe, and there's been a significant amount of, in these trials, dose interruption, dose reduction, or even discontinuation due to adverse effects. So in the last few years, there's been a new interest in using targeted therapy to re-differentiate these tumors that have become radioactive iodine resistant. So as I mentioned before, the part of the resistance due to the loss of the sodium iodide importer. So if we can re-express that, perhaps we can use the existing targeted therapy of radioactive iodine. So this is an example of a 72-year-old man with aggressive disease who's had aggressive surgery with no radioactive iodine uptake post-surgery, even in the distant metastasis. So was treated with lenvatinib for 3 years, but after that he developed progressive disease. And panel A here is taken this is a radioactive iodine scan taken after the 4 years of lenvatinib treatment. He was found to have the BRAF V600E mutation and therefore treated with 6 weeks of dabrafenib and trametinib. And this is the post-treatment scan. You can see all these lung mets which were not previously active are now very active, actively taking up radioactive iodine. So it has been shown that BRAF in recurrent patients with recurrent PTC, BRAF V600E alone confers a 70% chance of losing radioactive iodine uptake. Whereas if there was a joint mutation of BRAF and TERT, then that risk goes up to almost 100%. So there's been a few small series looking at how these treatments can be used to redifferentiate these patients. So all these series show that not all patients can be successfully redifferentiated, and even in those that have been redifferentiated, not all of them were successfully treated with radioactive iodine. And there's been a suggestion that there are few genetic alterations listed on the right here that can be associated with this phenomenon. So I just want to briefly mention that other than using them as targets to be for treatment and also for diagnostic purposes, molecular biomarkers can also provide prognostic information. And for a surgeon who is usually the first line of treatment for these patients with thyroid cancer, knowing what might come down the track is very useful. So TERT promoter mutation confers worse prognosis, and if someone has a TERT promoter mutation, we can be a bit more aggressive with our surgery. And also mutational burden is also an independent predictor of mortality and recurrence in thyroid cancer patients. And we know from the patients with the more aggressive types of cancer, they've also accumulated a few more key mutations there. So one of the barriers of apart from we're still learning a lot about these mutations and what they mean. One of the other barriers is really in the funding and the ability to for clinicians to accept their place in treating these patients. In the last couple of minutes, I just wanted to give you another example of what endocrine surgeons or thyroid surgeons have recently gone through over the last 10 years. Intraoperative neuromonitoring, when it was first introduced 15, 20 years ago, was thought by most surgeons to be a waste of money. It's hundreds of dollars to help me do something that I already do pretty well. As you can see from the first two rows, the rate of nerve damage is very low, 0.2% and 0.4%. So we are trying to use this neuromonitoring new technology to improve something that already occurred very rarely. Fast forward 15, 20 years. So this table is taken from the annual report of the ANZ Thyroid Cancer Registry. And one of the questions was whether neuromonitoring is used for thyroid surgery. Fast forward 20 years, 71% of cases were done with intraoperative neuromonitoring. In fact, when I was going through my training as a registrar, one surgeon used neuromonitoring. And now I can't tell you a single surgeon that I know who do thyroid surgery regularly who doesn't use neuromonitoring. So we have broken through this barrier before. And in fact, the studies can't even after all this time, studies has not proven the real benefit of neuromonitoring, but it's still become widespread these days. So with that, I'm going to conclude by saying that we need to start thinking or classifying these thyroid cancers according to their genetic alteration in addition to their histopathological appearance, and use that information to incorporate that information into our regular workflow to help us better diagnose, better treat, and better prognosticate for these patients. So finally, I would like to acknowledge the funding sources for my study, and as well as thank all the wonderful researchers and clinicians that I work with in these various institutions, and without their collaboration and the support, we wouldn't be able to do what we do today. So thank you very much.
Thanks very much, James. It's fantastic talk and overview. I think thyroid cancer is just one of the most interesting malignancies, certainly that I treat, and you know, really amenable to targeted therapies. I mean, I've had some really spectacular outcomes for some of my patients in the last 3 or 4 years applying these approaches. And actually interesting now also integrating treatment with immunotherapy. There's some really interesting early data, at least even in anaplastic disease, combining immunotherapy with some of the pan TKI drugs. So please post questions for James. We've got a few minutes for questions. There's one here, James. So are cytology samples sent for molecular testing after morphological analysis, or is a fresh sample required?
Yeah, thank you for that question. That is an interesting question. There are different ways. Usually a separate needle aspiration is required to get enough cells for analysis. The standard procedure would be to do 1 or 2 passes for the slides, and then an additional pass at the same time for molecular testing. If we incorporate that into our workflow, we're not doing that at the moment. And the other consideration is that at the time of the needle biopsy, we don't know if that sample is going to be indeterminate, or whether we're going to be able to get a determinate cytology. So to routinely get that extra sample is potentially a lot of work. So I know Vivek from Monash has started looking into whether the slides can, after morphological diagnosis and recording of with the photo, can then be used for cytological analysis. Sorry, for molecular analysis. Yeah, I'm not sure exactly where he's up to and whether how effective that is at the moment.
Okay, next question is from Vicky Marshall. Great talk, James. Have you tried using cytology SNT for tumour profiling?
Supernatant, that's supernatant. Yeah.
Yes, yes, that's another very good question. In fact, Michael Mon and his PhD student and Peter Fuller's group in Monash are actually doing a study on using the supernatant. So hopefully in the next seminar that we give, we'll be able to give you some outcomes of that.
Thank you. Oh, that'll be great. Actually, Mark, I've got another question, if I can just ask.
Go for it.
Yeah. Let me know if I've got the procedure wrong, but so basically you take a sample in addition to the normal biopsy sample you would take, you would also take an extra one for tumor profiling, right? So they're not exactly the same. It's right.
No. So yeah, so very sharp, Vicky. So one of the weaknesses of our study is that when the cytology that was taken for diagnostic purposes before the patient comes to see me, and the samples that I take after they've gone to sleep, just when they're about to have surgery, you know, there's a potential that, I mean, I review the ultrasound of the procedure to make sure that I think I'm taking sample from the same tumor, but I can't guarantee I'm taking sample from the same part of the tumor.
Yes.
And yes, so with different passes, there's always a potential that the cytology and your molecular findings don't completely match up.
Yeah, yeah, cool. And the reason I asked that question is because that's basically exactly what Dan Crow's doing for his pancreatic cancer study, and they do have some occasions where the their standard of care testing on the FNA biopsy or cytology, and then it doesn't match up with the next generation sequencing results, and sometimes they attribute that to it being a different sample or taken from a different part of the tumour. So I was also wondering, when you had some false negatives, false positives, I can't remember, some mismatch between the biopsy results and the next gen sequencing. Some of them could be due to like sampling. I guess it's called sampling error.
Exactly. No, that's exactly right. And that's also why I made the comment that we need to look into those further, go and review the images and go and see. Because one of them, I thought I took 2 different samples from 2 different nodules within the thyroid, but it turned out that no, those 2 nodules are actually one big lobulated nodule. So again, we just need to spend a bit more time to go into these details to clarify those things.
Great, thank you. And great talk, by the way, that was awesome.
James, I might just ask a final question. What do you think, what's the future of neoadjuvant therapy, particularly targeted therapy in this disease, do you think?
I think
I'm talking systemic therapy.
Yeah. I think for those that are deemed inoperable to start with, there's definitely a place. So patients like the example that I gave of the anaplastic, and potentially others will be polydifferentiated or very aggressive follicular cancers, and also ones with wide metastatic disease with very small primary disease. If the other disease can be kept under control, then there's more reason to go and operate on their neck. Because at the moment, sometimes when they have widespread disease, and if there's no threatening to the airways or any structures in the neck, we may not be doing surgery up front.
Okay. Great. All right. Well, thanks so much, James. Just wonderful talk, and we're super happy to have you contribute to our series and present the last lecture for 2021, and all following your research and career development across the Monash Uni affiliate precincts. So well done. Thank you.
Thank you very much.
Thank you also to the attendees for today's seminar. Fantastic turn up again. The next seminar is scheduled for February 2022. And obviously details around that will be circulated closer to the time, but the lineup for speakers next year is looking equally as spectacular as the lineup that we had in 2021. Please keep up to date with these seminars and other activities by visiting the MPCCC website at www.monashpartnersccc.org and also subscribing to our Twitter and LinkedIn feeds.